Hello. Hello. Good morning to our distinguished guests and participants. As we are embarked on the last day of our national conference, which is organized by Department of Biotechnology, Veer Narmad South Gujarat University, celebrating 68th years of our establishment. I would like to acknowledge our sponsor, Defense Research and Development Organization, DRDO, Government of India, New Delhi. I hope the final day unfolds with the gratitude for the insightful discussion and diverse perspectives that have enriched our discussion. Now, I request Dr. Mansi Mehta ma'am to please come forward and welcome our expert speaker with the beauty of worldly art and the traditional gaze of kings. As we are beginning with our technical session 4, which is delivered by our expert speaker Dr. Prem Yadav sir on a topic recent updates in a treatment of neuropathic pain and depressive disorders, I request Dr. Mansi Mehta ma'am to introduce our expert speaker and sharing his remarkable achievements and contributions with our attentive audience.
Very good morning, everyone. It's an honor to give introduction of Dr. Prem Yadav sir. He is currently designated as Principal Scientist and Head at Division of Neuroscience and Aging Biology, CSIR-Central Drug Research Institute, Lucknow. He was postdoctoral fellow at Department of Biochemistry and Molecular Biology, New Jersey Medical School, USA. He has done his PhD at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, in immunopharmacology. He received Ramanujan Fellowship Award from 2012 to 2017 and also honored with Young Scientist Award by Serotonin Club Meeting 2010, Montreal, Canada. He has 5 patents on his name and published more than 25 papers and 6 books in peer-reviewed international journals. He received research project funding from various national and international funding agencies like Department of Biotechnology, Ministry of Science and Technology, Government of India, National Institutes of Health USA, Office of AIDS Research under the Intramural NHI to India Program USA. I would like to request Dr. Prem Yadav sir to come upon the stage to continue the session.
I can manage it. Good morning, and thank you, Mansiji, for kind words. So, I will be taking you through, although I made my slides keeping in mind that mostly would be the students. So, more sort of it's educative, but I had tried to give you little bit flavor of what we have been doing at CDRI for last 10 years. So, what in data terms or the science, actual science, what we have been doing, I will tell you the one small story of discovery of a compound which we are positioning for peripheral neuropathic pain. So, like the title goes around, recent advances in treatment of neuropathic pain and depressive disorders. So, you might be wondering why pain and depression together. So, I just want to tell you, yeah. So, pain circuitry and depressive circuitry goes in hand in hand. Just giving you an example of one thing, like when you have a low mood, when you are not feeling well, something has happened in your family or something, even slightest hurt gives you a lot of pain. So what I was alluding you to, two things. One is that pain has two components, clearly. One is like, okay, yeah, I keep like moving, sorry. Yeah, so pain has two components. One is the, like when you get hurt in tissue damage, you obviously feel pain. But the other component of the pain is mood. So, or you can call it suffering. Let me give you another example. Like when you are playing in the field, you are playing your best sport. Even though you get hurt, but you don't feel pain. Why is that? Although you have a fracture, sometimes a serious injury, but you don't feel pain. Because at that time, there are certain neurotransmitters in your brain which are euphoric, like endorphins or dopamine, serotonin. These are the principal neurotransmitters, you can call it chemical neurochemicals, which keeps you at a high stage, elevated, and you don't feel the pain. So clearly, your mood determines your suffering. You might have a very big injury, tissue damage, but you're not feeling pain. So that's why pain and depression has a very overlapping neurocircuitry and goes hand in hand. So, yeah. Yeah, before I go ahead, tell you the full story, I would like to acknowledge the real people who have done the work. So these are my lab folks. Charlie, who is currently an assistant professor at Vanderbilt. Poonam is at Duke. They all graduated from my lab. Anubhav is completed thesis and would be moving very soon out. And she is my technical officer, who is works like a glue among all the other people. And these are my two colleagues, Dr. Sanjay Batra, who is a medicinal chemist, and Dr. P.P. Yadav, both are a medicinal chemists. So we have a very close relationship with the CDRI because they are the supplier of our new chemical moieties, and those are the substrate on which we work. And of course, our funding support from, so being in CI, one thing is good that we don't have to worry about a lot of money. We are very well funded. So I have this called Pan CSIR-IND mission. IND mission is new drug discovery. Whatever all across the CSIR, we are 39 laboratories. So out of 39 laboratories, there are about 7 biological laboratories, which works on the technologies related to biological science. So in CDRI we have a drug development program which is funded by Government of India. So this one of the molecules which I'm going to show you is funded by this mission where we have to, and this mission is ending in the March this year. So we have concluded this for a long time ago. And of course, some fundamental science is going to be here, which is supported by DSC. Just another brief view of our division Neuroscience and Aging Biology, where we are focused on the fundamental studies related to neurodegeneration and affective disorder, meaning affective disorder means psychiatric disorder like depression and neuropathic pain. My colleague Sonia, which is a recently recruited assistant professor at Aminaji, is also the senior professor, works on these 6 OSV, these Parkinson's disease models, Subha uses the rodent studies, while Sonia and Amir uses the trans-elegance, C-elegance models of the trans-elegance. My lab and one other professor, Dr. Arvind Chatterjee, works on the neuropathic pain. And then I have another models which are working on the Alzheimer's and cerebral stroke, another focus of my lab. And lastly, I work on the synaptic plasticity, like how the brain performs these functions, how the neuronal communication happens, and why it's the process. So with that brief background, let's come to the topic. What is the pain? So there are two categories of the pain. One is the nociceptive pain, another we call it neuropathic pain. In nociceptive pain, usually one is categorized as visceral pain, like you have intestinal perforations, injuries into the visceral organs, you will pain. And somatic, like musculoskeletal, you pulled up a muscle, or ligament tendons, all those sort of that. So these are the two categories are called nociceptive pain, where a tissue damage is primarily responsible for the pain. As soon as the tissue damage heals with regular analgesics, which is non-steroidal and analgesics, pain goes away. It's very common, happens with everyday life. So that's not the problem. The problem is neuropathic pain. So there are two kinds of neuropathic pain. One is peripheral neuropathic pain, one is the central neuropathic pain. Peripheral neuropathic pain, so I will be talking more about the peripheral neuropathic pain. How the central neuropathic pain is very, very severe and its occurrence is not that common. So, but in our daily life, I will tell you the incidence rate. A lot of people suffer with peripheral neuropathic pain. Right. Sorry, it's happening. I'm not very good.
This is for 20.
Yeah. Okay.
This is for 20 years.
How can we remove this? Yeah, it can't. So if you look at the incidence rate in our country for the pain, you will surprise. This is the peripheral neuropathic pain, examples of peripheral neuropathic pain. This is the central neuropathic pain. So post-heart neuralgia occurs around 8 to 10% of the population. And you might not know by the Disney common name symptoms, like you get the blisters on the back, like blisters like this, it's very high burning pain. So that's called post-herpetic neuralgia. Of course, you know diabetic neuropathy, when people are like 10 years or 15 years of diabetes, they develop severe neuropathic problems. And cancer. Cancer, of course, you know the leg cancer, and it's very severe pain. And people who goes for the chemotherapy, between the chemotherapy cycles, they develop a lot of severe category 8 to 9 pain because of the chemotherapy. So that we call it chemotherapy-induced peripheral neuropathic pain. And lastly, surgery. Of course, during the surgery, sometimes doctors have a problem like did some error, have severe impact. So that's how we use the peripheral neuropathic pain. Why am I talking this? And this is a lot. I mean, India is the capital of diabetes. Diabetes currently it's the highest number in the world. And think about it. How many people will go through this neuropathy? So this pain is very painful, considering our population. On the top of it, all the available medications does not work. So we have more than 2 dozens of analgesics of NSAID category, non-steroidal anti-inflammatory drugs. Almost 6 to 8 analgesics which have been approved to treat peripheral neuropathic pain. However, they work in only 20% of the people and reduces only 10 to 20% pain. First of all, it works only in 20% people. Then it reduces only 20% pain. Think about it. So it's a huge unmet medical need. We require new drugs. And currently drugs, besides the efficacy and there is huge adverse effect. If you have a low back pain, you go to the doctor, they will prescribe you SNRI, and you will be sedated, like you will be drowsy, and your pain will be out for 4 to 6 hours. As long as so you have to take twice a day or sometimes 3 times a day. But all in all, they will have a sedative effect. Besides sedative effect, you will have chance if you are unfortunately have a cardiovascular problem like hypertension, diabetes, then it has a lot of cardiovascular liabilities. So all in all, we don't have a currently available safe, efficacious drug which treats peripheral neuropathy. So that's the precedence for us to find a new drug candidate. What is the mechanism? How does the analgesic work? So this is just a simple cartoon. So like you have a prick on your finger. So every micrometer of our body is innervated by neuronal fibers. Like you touch it here. How do you feel that you touch? Because as soon as you touch, a sensory neuron is activated and transmits signals to your sensory cortex. So it is going from here to spinal cord, and from a spinal cord, another set of neurons is transmitting the signal to your sensory cortex. So, and now you are recognizing you have touched this part. And this happens in millisecond level. So it's a very fast communication system. So there is, So there is a system. So this is first order neuron. There is a neuron in your fingertips coming all the way to DRG, which is called dorsal root ganglia. It is a button-like structure which is protruding towards spinal cord. Spinal cord के बगल से थोड़ा सा बटन बना होता है, उसको कहते हैं dorsal root ganglia. वहाँ, so the cell body of this neuron is dorsal root ganglia, and this projects again back to the main spinal cord. So this neuron is bimodal. One part of is innervated in your somatic system, other part is connected into the spinal cord. From spinal cord, there is another set of neuron which is taking this message and communicating to the brain part called thalamus. From the thalamus, another set of neuron connecting to this signal, taking this signal to sensory cortex, which is outer part of our brain. Cortex is bark, very sharp. So this is one of our most important part of our brain. See, between mouse and us, it's a trillion years of evolution difference. Essentially, genetics-wise, and you take chimpanzee, our closest relative in the evolution, it is still a billion years apart. Difference between us and chimpanzees are only the thickness of cortex. आपके दिमाग की जो छाल है, thickness of, that's the only difference. Otherwise, we have no difference. So that part, that outer layer of our brain, makes us the consciousness, decision power, and so many other brain factors have our brain functions that's residing only in that particular part. Rest is the same. You feel hungry, you eat. Other animals will hungry, you eat. Every other physiological process is all more than 99% same. So we are human beings, as a human being, are distinct only because of roughly 1.5 centimeter difference in your brain. That makes us human beings. So that's a very small difference though. So, yeah, Yeah, so this is a normal, just a very simplistic way of understanding brain transmission. And see, we have more than 1 billion neurons, more than 1 trillion synapses. So, as an understanding part of it, we don't understand even less than, less than 0.001% of neuronal communication. That's our understanding as of now, and we think that we know everything. Already, we know nothing. It's such a level of complexity. So, in last 10 years, United States make a consortium worldwide called the Human Brain Map. They spent almost $5 billion a year. It's going on for last 10 years. $5 billion per year, and it's across the world, hundreds of scientists working to map the brain circuits. That one small circuit is involved doing what? So that kind of expenditure and focus is going on around these days. And our whole science budget of this country is less than 1 billion. Think about it, where we stand now. How can we make a difference at a global level in understanding the physiology and medicine? But still, we are doing our part at the best what we do. Moving forward, what are the currently treatment? I just like told you in the beginning, there's very little out there. So for peripheral neuropathic pain, like you have burning sensation or like you have burn, we have approved leg pain plasters. Yeah. And the second level, capsaicin. Capsaicin which larger sections may take care of the capsaicin. When you eat, you feel burning sensation. Because it activates the ion channel called PRP1, drift like ion channel, and it gives you a burning sensation. So in pain, in certain kinds of pain also you feel burning sensation. So what does this do is, you bind on the receptor, capsaicin binds on the on chilies, and down-regulate that receptor. So it's like लोहे को लोहा काटना है, जहर को जहर मारना है. तो उसको इतना जहर दे देते हैं कि वो रिसेप्टर ही गायब हो जाता है, तो बर्निंग सेंसेशन थोड़े दिन के लिए खत्म होता है. But that's a temporary relief, that matter. And these are the drugs available, Velocity, venlafaxine, gabapentin. I'm sure many of you, those who are above 40 years, have taken these drugs, tricyclic antidepressants. They are highly sedative. They dump down your pain for 4 to 6 hours, but as soon as the drug is metabolized, pain reappears. Tramadol and opioids comes to the next therapy. Yeah, and then all these things are there, but these are not for the general population. What works are like injection, IV injections. You have to go to doctor to take your injections. So some of these, what I am trying to tell you is that there is a huge medical need. Currently, drugs are not available because of so many other reasons I already told you. Now, first of all, how many of you heard of opioid? Morphine, everybody. So, morphine is a substance isolated from a plant, and it is being used since 1300 Sumerian era. And it was used, first known use of morphine is for cough and diarrhea. Later on, in 1970, people found that it causes analgesia, pain relief. So, as of now, morphine is the most commonly approved last resort for the pain. But the bad side of the morphine is that it is addictive. If you take once, you feel like you want to take more. Second thing is that development of tolerance. So for a pain, you take 10 milligrams of morphine one time. Second, if you have the pain, 10 milligram would not work. You have to take 15 milligram. Development of tolerance. So you develop tolerance for the morphine and similar compounds which work through the opioid receptors. So there are three opioid receptors, mu, delta, tau. So morphine M is mu, works through the mu opioid receptor. So the third aspect which I saw, development of tolerance and addiction. The third basic and very important side effect or that most serious adverse effect is respiratory depression. आपकी सांस कम होगी, आप सांस नहीं ले पाओगे. That's why all heroin addicts die overdose because they take more to have a more euphoric effect and end up into overdosing themselves and they die. So that's the three major side effects of opioid medication. Although they are very good in suppressing your pain, right? But they will develop tolerance, they will be able to have addiction because you get a euphoria, hallucination, all those good things happen because pain will go away. And what you feel is, remember very well, is not the pain, going away the pain, the euphoria. You like you're floating on the clouds. That's the euphoria. So that's why they are very highly addictive. So all these drugs, all these opioid medications work with opioid receptors. And there are three opioid receptors, mu, delta, gamma. I already told you respiratory depression, constipation, addiction, these are the adverse effects of the working through the mu opioid receptor. Delta also causes addiction and it causes convulsion, maybe less. And the gamma opioid receptor is something very important. It causes analgesia, but it causes dysphoria and diuresis, a lot of urine formation. And dysphoria, you can call it very sicky mood. Very sicky mood. Like if you take one time, you will feel so bad from inside that you don't want to take it. That's called dysphoria. And some of you will feel a dissociative effect. I think some of young folks might be knowing salvia or salvia. Have you anyone heard of salvia? Salvia is a meat family plant, originally found in Mexico, but it grows in India also, but not beautifully. So salvia is has a compound, is a chemical found in salvia, it's called salvinoid. It is the most potent hallucinogen on planet Earth. You take 10 milligrams of the salvia, you will be out of this time and space zone for next 30 minutes. Next 30 minutes. So you lose the time and space. You transport yourself somewhere. But at the same time, it has dissociative effect, like it's very practical. You become table. You become wall. You become like any. You can become any inanimate object, and you will so frightened that you will never be able to take. You don't want to take them. So that's the adverse aspect of this opioid receptor ligands. So, but in last 10 years or so, a new theory came in. We call it biased agonism. Sorry, I will be going little by slow so that you can catch up because later on it will become too complicated. So I am going relatively slow. So, a ligand binds on the receptor and transmits the signal inside the cell and cellular response happens. So, earlier what you know is a ligand binds like binding pocket of the receptor is the same. So, anything going in will have similar outcome inside the cell. But no, that's not actually true. That we came to know in the last 10 years that a compound binding two compounds can have two different outcomes depending on their intrinsic property of the ligand. not the receptor. Receptor binding pocket is fixed. So two ligands binding on the same receptor have a completely two distinct cellular outcome. We call it a biased agonist. But one compound can be biased towards one partner, other compound binding in the same pocket can be biased towards different partners. How does that happen? So I will just leave this part. I already spoken to you. Yeah. So since what we discovered is kappa opioid receptor agonist, this kappa opioid receptor is expressed in both CNS, periphery, and more so in our intestinal wall. Activation of this receptor causes analgesia, but induces sedation, motor incoordination, and dysphoria, like I was telling you, Salvi Nori story. So, for this matter, nobody tried to develop drugs against this receptor, although it causes analgesia, but because of dysphoria and motor incoordination and sedation, nobody tried for last 10 years, not last year. So the last molecule was in enandolis in somewhere 2003 phase 3 clinical trials, and people found that they becoming stone-like people. So they said no, you cannot develop the drug against that. But this story of biasagonism, which came in the last 10 years, has been proven that biasagonist will not have adverse effect like a normal agonist. We can still try it. So this is a classical pathway of any GPCR. So G protein coupled receptor is a family of receptors in our body, which is about 1,000 in our body. And it regulates every single thing what we do. It's as simple as that. And it activates the ligand. It starts from the light photon, rhodopsin. In your eye, you see this word because of the GPCR named rhodopsin expressed in your retina, which is activated by light photons. So that's the family of the receptor. And so it starts, and almost 60% of the drug approved by FDA or any world drug regulatory agency is a GPCR ligand, and this G protein coupled receptor ligand. So it's a very high druggable target and very popular target for making new drugs. So this kappa opioid receptor, so of course, if it activates this pathway, it will have analgesic response. But another aspect of kappa opioid signaling is called estrogen recruitment. If this pathway is activated, it's called sedation and anhedonia and reduced motivation. So if a G protein biased agonist will activate this pathway more, we'll call G protein biased. If it activates more of this pathway, we'll call beta arrestin biased. If it activates both pathways equally, we'll call it balanced agonist. So there are, when you find a ligand, there are three possibilities, either this or this or this. So earlier, what we knew was only this, that the agonist will bind to the receptor and activates both pathways with almost equal affinity and efficacy. That's called biased agonist. And that's how Mark or other we does. So it activates analgesia, but activates the arrestin pathway, and because of that we get a lot of respiratory depression and so on and so forth. So what we wanted to have is find a ligand. Yeah. Yeah, sorry. So what we wanted to have is find a ligand which activates this pathway more efficiently rather than this. So we'll have analgesic response, but not the adverse effect. That was the hypothesis. So we went on to do a blind screening. So we had a program earlier back in days, we called MOES program, which is drug from the sea. So people, we went on the sea, bring out the material, isolated the chemicals, and we screen, blind screen. We don't know what's coming out, which is blinded screen. So we had the platform or high throughput screening platform where we can screen 500 molecules on a day. So it's very robust platform. And these platforms are very well designed platforms. So we library of the compound, screen on the all three opioid receptors. If a compound found on the less than 100 nanomolar activity, take look for the other pathway. If it is more than 100 nanomolar, then took the stability, toxicity, safety, and then take to the mouse model for efficacy. And these are the jelly sensor based assays, very high throughput, but very well designed assays. So I will not go into detail on this because this is very complicated things. This is based on the signaling assays. And this is all done in live cell. So if a compound is too toxic, it will kill the cell. We'll know that it's thrown that way. So almost 50% comes very toxic, which is not tolerable. So we throw that. And 50%, so hit rate, like if I screen the 3,000 compound on the sea, I found the hit rate was 0.1%. So from that, we found a couple of compounds. Once we find a hit, then our medicinal chemistry team comes into the play. So they found the structure, now they start synthesizing the molecule based on that hit. So that hit is not a drug molecule because it will have a finite content in the main one. So it will have lots of other things. So they have to develop that. That's called discovery and development. That's where development. So you found out the active molecule, but that cannot be drug. Hardly any molecule besides antibiotics. So you found a very active molecule from fungi or bacteria kills bacteria. So that could be a drug because you want to kill it. But for us, it has to be tolerable, less adverse effect, and should reach and metabolize the way you want. So there are a lot of things which has to be optimized. So coming to this molecule, what we have discovered, a very nice molecule. So I will not go into the chemistry. I think none of you might be belonging to natural chemistry. But this is the molecule. So this is the molecule. So we have to derivatize every single possible arms to see which one works better and how this structure binding is working. So it's called SAR, structural activity relationship. So in drug discovery, this is the thing. This gives us the intellectual property right. Without this, you cannot have IP. So we derivatize on every possible way. So from that thing, we synthesize more than 200 more molecules, chemically synthesized, and work out which one it works better. So we had from the SAR, we found almost 14 active compounds with less than 50 nanomolar. And out of them were 6 were G protein biased. And this we selected, filed a patent in 22. So up to this point, I have spent 7 years, 2 PhD students, nothing on in their thesis, neither published. So now you can think of the dilemma of the student and like everybody works for the career. But if you are in this business, first of all, you are 99.9% bound to fail. So you're working on the 0.1% chance. But this is how it works. You cannot do things other way around. So now the patent is filed. I will show you some of the glimpse of the data. So why we call it biased agonist? See, this is growth sensor assay. This is G protein signaling pathway. You just look at these two numbers, minus 9.3, minus 8.9. So U50488 is balanced agonist, commercially available, used as a comparator, and our molecule 105 here. So on this G protein dependent signaling, both has a similar affinity. It looks like the same. But when we did the arrestin tango assay, which is the arrestin dependent signaling, again on through the same receptor, look how much separation we got. Yeah. So see, balance agonist so high, our compound is so little. So we call it, so this compound activates this pathway, G protein pathway, but less this pathway. This is called biased agonist. And so there are three receptors in our body. Three opioid receptors. It should work, it should be fairly selective. So selectivity shows our compound is working through the kappa opioid receptor. The 3 nanomolar versus 5 micromolar versus 0.8 micromolar. So 100-fold selectivity. So some of the assays were done abroad because we cannot do in our country. So now coming to the last thing. So this is the molecule. I think I have 10-15 minutes. So neuropathic pain. Majority of you will be knowing lower back pain. Especially in our ladies about the 40 and BMI more than 27 will have a lecture. It will happen if you are not taking report. Lower back pain is 70% prevalence in India over 40 years of age. If your BMI is over 57, so you have to watch your weight and your physical, how you operate. So it's going to happen. So lower back pain is very common and it's a neuropathic pain. Believe me, you will take medicine, it will go away for a few hours, but next morning you will have again. It happens with many people. Sciatica, I'm sure many of you have heard. You see radiating pain from coming from the lower limbs to goes up to the back. Sciatica. So this is the model, and that's a neuropathic pain. Once you have sciatica, you suffer like crazy. It happens, you take medicine, goes away, but it doesn't resolve. It resolves only with some of the yoga and physiotherapy and meditation. So physiotherapy, yoga, and meditation. Three things together for a month period, you will be able to take care of. But not only because of meditation. So this is how we model it. We take the rats, we ligate the sciatic nerve. This is spinal cord, and this is the sciatic nerve. There are three levels, L3, L4, L5, 6. So we will make 4 loose knots. This is our picture. That's how we open this part here. We take the sciatic nerve. थोड़ा धीरे से धागे से बांधते हैं नर्व को काटते नहीं थोड़ा सा तो it more like compression of that nerve. And for pain, whether they are feeling pain or not, so for heartbeat test, so we take the rat and on the hind part we focus a beam of light. So beam of light generates heat, right? So normally अगर आप नॉर्मल आदमी दिए के ऊपर उंगली रखें तो आप 20 सेकंड तक रखें। अब 6 इंच दिया जल रहा है 6 इंच के ऊपर आप उंगली रखें या पाम रखें अब 20 सेकंड तक दर्द नहीं महसूस करेंगे। लेकिन अगर आपको न्यूरोपैथिक पेन है तो जो 20 सेकंड का टाइम था आपको 5 सेकंड इसको कहते हैं सेंसिटाइजेशन ऑफ नॉक्सिस। तो आपका जो पेन बियरिंग कैपेसिटी थी वो कम हो गया, उसको हाइपर सेंसिटाइजेशन ऑफ नर्व बोलते हैं। दैट्स व्हाट वी रियलाइज। So normal rat can bear that heat beam for 20 seconds. But if it has developed a neuropathic pain because of the surgery or for some other reason, the pain threshold capacity, the time bearing capacity will come down drastically. And other thing which was non-brain test, we call mechanical allergomy test. You might have heard that normally touch is weird, not painful. But those people with diabetic neuropathy or cancer-induced neuropathic pain cannot get the socks in. Even touch, it's so painful. You touch it, it becomes painful. Cannot wear with cloths. Undergarments wear convenient color. So even touch. So what we do that, we take the mice, this is mass kind of जाली है, उसके नीचे से एक फाइबर, हल्का सा फाइबर से छुआ दे, तो नॉर्मल अगर क्रैक होगा तो कहीं नहीं होगा तो है कि नहीं है, and that touch is measured into the gram force. How much force is applied is measured into the gram. So normal rat can bear up to 40 grams of the pain. That's pressure. But if it is neuropathic pain, the 40 grams up to the 10 grams. Like when you're wearing gloves, you're touching, you're still feeling painful. That's real neuropathic pain. So these are the simple assays done in our lab to measure the model neuropathic pain in the rats and mice. So using this model system, we did that. Finally tested our compound. So this is the acute effect. We injected the drug and measured the pain right after half an hour after injection. Of course, any analgesic, if you take the drug, your pain will go away for some time. It's called acute pain. But if you take the pain medication for 7 days and if you don't take your pain threshold is completely normalized, then you will say disease is normal. Right? You cure the disease. So neuropathic pain, of course, how long you will take medication? Definitely, because every drug has some or more adverse effect. So it will be having a toll on your body. So our objective is to cure the disease. To treat the disease, not the symptom. Symptoms, of course, any analgesic will treat, and we have dozens of drugs to treat the symptoms. But we want to treat the disease. So here is the, so of course we make a model, we tested it, we see this is the 30 gram, we see threshold 30 gram. Now after chronic obstructive injury is come to the 12 gram. When you take the compound, our compound, green and the red, green, this is green and blue is the unbiased, and this you see it goes away. So it is analgesic. And this is quantified here also in other thermal temperature with barbitol latency in second, and normal mice or rat will have 15-second withdrawal, like I was telling DA के ऊपर हम 15 सेकंड रख पाएंगे हीट पे, और जब न्यूरोपैथिक पेन होती है तो ये 15 ग्राम से 15 सेकंड से 5 सेकंड आता है, दैट्स न्यूरोपैथिक पेन. जब इस पे ड्रग दिया आपने, ये वापस 15 सेकंड के पास पहुंचना चाहिए, और ये अनबायस्ड. So it's after injecting the drug, you see that this is normal. Well expected, this is gonna happen. But after 15 days of injection, what happens? When the drug is not working. So we gave the compound of a test item, this drug, for 15 days to the rats, and measure the effect on 16th day, whether the mouse or rat is still having pain or not. And this is what it is. So normal rat, which was never went to the surgery, still have the same normal life, and the rat which had went to the surgery, pain threshold is on, still after 15 days, and the compound was treated for 15 days and tested on 16 days without any further infection. You see normalization like this, and our unbiased agonist is not so well, and same in this parameter. So this is what called efficacy in animal models. So that was the one model set. This is another model we call peripheral chemotherapy induced peripheral neuropathic pain. So what we do is we inject the mice for 6 days with paclitaxel at 6 milligram per kg. Paclitaxel 1, 3, 5, 7 days, one alternate days, and then we measure the pain. So just injecting a normal mice paclitaxel induces peripheral neuropathy, because paclitaxel goes and binds to the dorsal root ganglion neurons and degenerate them. So that's how you develop a peripheral neuropathy. And you see our compound given at 5 milligram per kg, 10 milligram per kg, you see normalization towards happening. And duloxetine, which is FDA approved analgesics for neuropathic pain, also does, but our compound is even better than this. And this is done in hyperresia model as well as hypertonia model. This is a fairly complicated data. I don't expect you to understand everything, but this is just an example. So we tested our compound in 2 models and it found good. So far so great. We are very excited that wow, we have found something really good. But yeah. So another aspect was that okay, what happens is efficacy is good, it is analgesic, but does it have dysphoria, hallucination, motor sedation, which is normally unbiased to have. So this is the rotor rod test. So we put the mice and then rotating rod. So it is moving at 20 RPM. And mouse learn to coordinate with that rotating rod. So rotor rod. So their neuromuscular coordination has to be very nice to keep moving on the rotating rod. So if a compound has a sedative effect, they will fall out in a quick second. Or it is a paralyzing effect on neuromuscular coordination, again fall out. So this is the way test to have that. So we put the mice on rotating rod and you see for 5 minutes in this 300 seconds, and normal mice will have this 300 seconds. But if a compound like the unbiased agonist, kappa opioid receptor agonist, which is known to induce sedation, muscle incoordination, falls out at 30 minutes and 50 minutes. However, our compound does it. That's the beauty of biased agonist. It does it. And sedation. So we put a mice in open arena by 1.5 by 1.5, a simple box, and put them in video recording. How much running they are. So normally it's a new arena problem, they are curious to explore, so they move around. But if a compound is sedated, they will go and sit in the one corner. So look at this compound. So normal mice, see, start running, and slowly when they have explored every nook and corner, they come and. So with time you see their activity, spontaneous locomotor activity goes down. So our compound, this is also like that, but U50 is highly sedated, unbiased kappa opioid receptor. And this is dysphoria. This is very complicated task paradigm. So I can give you the example. So those people who are drug addicts, you put them in rehabilitation center. They come back after 3 months spending in rehabilitation center, their reaction is gone. But as soon as they walk through that corner from where they used to get their drugs, it's called conditioned place preference. जिस कोने पे ओवर मिलता है या पुड़िया मिलती है, उस कोने पे आप ज़्यादा टाइम खर्च करना चाहते हो। ब्रेन का सर्किटरी इस तरीके से एडजस्ट होता है। तो उसको कंडीशनड प्लेस प्रेफरेंस है, वहाँ पर आप ज़्यादा प्रेफर करोगे। तो उसको माइस में कैसे करें? इसे ह्यूमन करना था, but what we do, we take a 3-chamber box. एक में जब उसको ड्रग देते हैं, तो उसको लाइट चैम्बर, एक को डार्क रखते हैं, एक को लाइट रखते हैं। तो अगर ड्रग तो माइस को इंजेक्शन देने कंपाउंड का, उसको डार्क साइड ऐसे करके 15 दिन देते हैं, इंजेक्शन देते हैं डार्क साइड। तो अगर फिर 15 दिन बाद 3 दिन का गैप छोड़ देते हैं, तो 18वें दिन जब लाते हैं और उसको इंजेक्शन देते हैं और 20 दिन को उसको चॉइस देते हैं कि किधर जाएगा, डार्क साइड जाएगा कि लाइट साइड जाएगा। अगर ड्रग एडिक्टिव है तो जिधर दिया है उधर जाकर वो बैठा जाएगा। अगर अपोजिट टू एडिक्शन है तो अपोजिट जाएगा। तो अगर कंपाउंड डिस्फोरिया दे रहा है जो कि अपोजिट टू एडिक्शन है, यूफोरिक रिस्पांस एंड डिस्फोरिक रिस्पांस। अगर यूफोरिक है लाइक मॉर्फिन है, हेरोइन है, कोकेन है, अल्कोहल है, अगर इसको देंगे तो उसी पॉइंट में जाकर वेट करेगा अब आएगा मिले और वेट करते। अगर इसको ही कंपाउंड है जैसे लिथियम क्लोराइड, अब लिथियम साल्ट होता है, अगर आपको बहुत ही जिसको मतलब टेस्ट एवर्जिंग बहुत ही गंदा सा मुंह में टेस्ट करता है तो या कौन में मिक्स तो अपोजिट साइड पे आके बैठे जिधर दियो तो वहां नहीं जाए अपोजिट साइड पे। So we call condition placed preference or condition placed aversion. CPP, CPA. So if the compound is additive, they will have a condition placed preference. If compound is aversive, dysphoric, it will call CPA. We measure that. So our compound does not have a CPA, condition placed aversion dysphoric. Why? So this is every dot represents a mice or a rat. So this is how it is. So far what we observed that compound is not dysphoric, not sedative, not neuromuscular important. Yeah. So the next question comes, okay, at efficacy goal, it is not causing side effect. But it is tendency to have like if you have one painkiller, एक dog है कोई मजा नहीं आ रहा कुछ हुआ नहीं उसके बहुत खाते बहुत सारा टेंडेंसी होती है अगर आपको बहुत ज़्यादा पेन है आपने गोली खाई आराम नहीं मिला 1 घंटे में एक और खा लेते शायद आ जाए और कुछ लोग और भी पैसा होते हैं ये बहुत सारे घंटे बाद तो it's very so we anticipate that by accident or by tendency, you might end up taking 10 times of the dose prescribed dose. So the compound, the test drug, has to be safe minimum 10 times of the prescribed dose. So we have to, that we call safety index. Every compound, every molecule what you take, what every drug, गलती भी हो गई तो 10 टाइम तक माफ हो जाएगा 10 मिनट तक उसके ऊपर मुश्किल So we tested our molecule just to have a safety index idea up to 10 times. So molecule is effective up to 10 milligram per kg. So we tested up to 50 and 100 and this unbiased evidence. So see up to 50 is normal like unplayed. 50, 100, 50, 100. So we have to demonstrate this before we go phase 1 clinical trial in human being. So these are all the regular data. Yeah, so this is one of them. So we have to do called pharmacokinetic profile. You inject the drug, then you take every body part, where compound is going, how much is staying, how much is it going in urine, blood, brain, every part. So we have to establish a clear-cut relationship between our molecule and that. हमने कर दिया हर घंटे 20 मिनट 1 घंटा 24 घंटे तक उसको मॉनिटर करना पड़ता है कितना निकला और कितना इफेक्ट है उसके हिसाब से इफेक्ट है. So this is what done plasma, brain, everything measured, and we injected the compound. This is IV injection. This is oral administration. We see it is not going into the brain. That's why it's called peripheral kappa receptor. So it is producing the effect by going only up to the dorsal root ganglia. Dorsal root ganglia is part of peripheral nervous system. So our compound is activating kappa receptor present on the peripheral nerves, body, intestines, and everything, and inducing the analgesia. So we tested with another a compound which is not going into the brain, blocks the opioid receptor in the periphery, and we saw that our effect is completely gone because of that. Just to prove that this compound is not going to central nervous system, working to the peripheral nervous system. So that's that. I will just take 2 more minutes to prove this. So I thought I will just give a glimpse of it. What is depression? Everybody knows it. but sometimes you say, we call it very depressed. That's not depression, believe me. Many times you feel depressed, but that's a transient mood. So what is depression? If you have these symptoms for consecutive more than 2 weeks, then you can say, and that too, rated by a psychiatrist, not by your mother, parents, or other colleagues. A professional psychiatrist insert a handy score, handwritten scale, to measure this change in sleep pattern, loss of appetite or weight, unexplained chest pain, continuous feeling of sadness, tearful, guilt, suicidal thoughts, so on and so forth. This is battery of the symptoms which is inserted by a trained psychiatrist and gives you the score out of 20. If your score is more than 12, and that score is after the persistent symptoms of more than 2 weeks, then you will be categorized as depressed. Okay, not that on given morning I'm sad because I had exam after 2 days. Right? That happens very often. We also have. So, I want to remember these 3 things. This is called cardinal symptoms of depression: anhedonia, asociability, and behavioral despair. Anhedonia is like everything what you do in your life is pleasurable, otherwise you won't do it. आप रसगुल्ला क्यों खाते हैं? मिठाई क्यों खाते हैं? आपको डॉक्टर ने तो कहा नहीं, बॉडी तो कहती नहीं कि रसगुल्ले की डेफिशिएंसी हो गई है. अच्छा लगता है ना, pleasurable, tastes good. It's called palatable because brain says you tasted one kind of rasgulla or good food, you demand more. We call it anhedonia. So hedonism, anything you would like, do in your life. If it is not pleasurable, you will not do it unless it is your fault. So that's called hedonic response. So in depression, you don't get pleasurable response of normal things what you used to get. Like खाना क्यों खाते हैं? भूख लगने की वजह से 90% आप लोग खाना इसलिए खाते हैं क्योंकि मजा आता है. Really? आप अगर खाना इसलिए तो खाएं कि फ्यूल की वो चाहिए बॉडी को रन करने के लिए, तो आपकी आधी समस्या दुनिया की खत्म हो. खाना इसलिए खाते हैं क्योंकि मजा आता है, तब तक खाते हैं जब तक मजा पूरा नहीं होता. तो वो चीज एक प्रॉब्लम है. तो हेडोनिक रिस्पॉन्स, आपके ब्रेन का सिस्टम इट्स गिविंग यू न्यूरोट्रांसमीटर व्हिच मेक्स यू फील गुड. दैट्स व्हाई यू ईट. So that response is gone. Anhedonia, that's called anhedonia. That's the first cardinal symptoms of depression. Asociability, अगल बगल बातें खूब करते हैं, लोगों से इंटरेक्ट करते हैं, वो भी एक इम्पोर्टेंट आपके जाए. So that goes away in depression. You don't like to talk. You like to spend time in the corner of the house or wherever you are. Called asociability. You don't like to socialize. Behavioral despair. It's a very important aspect of your life that if you feel challenges, you address the challenge. If you are difficult, you challenge yourself and you move for motivation. But in behavioral despair, you surrender to the object. You surrender. That's called behavioral despair. And from there on, suicidal tendencies come on. So when you give up, you don't like to struggle, you don't like to fight. Behavioral despair, that's where behavioral despair, suicidal tendencies come. And believe me, India is one of the top countries in suicidal tendencies. And almost more than 90% of the suicidal incidents is depression, undiagnosed, untreated depression is the cause. As we see in younger generation. Because psychiatric disorder in India is a social taboo. पागल हो गया, लेवल कर दिया. It's a serious issue. We should recognize and respect social psychiatric issues. Everybody has to go. It's very common considering our civilization and the pace of our development, society, and so on and so forth. Everybody is under the pressure, social pressure, peer pressure, so many kinds of pressure to perform, to be better. And everybody is not the same. So they are bound to have psychiatric issues. So rather than enigmatizing it, making it taboo, we should consult them to see the psychiatrist. Take the medication rather than making it. So that's what the main reason is. So undiagnosed and untreated depression is the primary cause of suicide in our country and everywhere. So, and pain also comes. So if you are depressed, you will feel more pain. Pain and suffering goes is like opposite direction. So you might have a pain, but you don't suffer. Right? And the one is no. It's a pain. But you can suffer a lot, or it's your decision. So it's the suffering and pain, like I was telling, nociception and suffering is two distinct phenomena. आपको दर्द हो रहा है एक प्रोसेस है, दर्द से दिक्कत हो रही है वो दूसरी प्रोसेस. तो वो चीज है. तो अगर आपका मूड डिप्रेशन में है तो दर्द से दिक्कत ज्यादा होगी, दर्द भले ठीक हो जाएगा लेकिन दिक्कत बनी रहेगी. So these are the something. So this is the, I will just be very quick here from on now. So normal mood, depression. So severity scale है, आप ड्रग लेंगे, एक्यूट फेज कहते हैं 6 से 12 हफ्ते लगते हैं. आप अगर डिप्रेशन में हैं तो आपको धैर्य और परसिस्टेंस सबसे इम्पोर्टेंट फैक्टर है. आज की तारीख में कोई भी एंटी डिप्रेशन एंजाइटी ड्रग नहीं है जो मिनिमम 4 वीक्स लेती है इफेक्ट देने. मिनिमम 4 वीक्स. आप एक डॉक्टर से दूसरे डॉक्टर तीसरी दवा से चौथी दवा जंप करके रखते हैं, वो असर नहीं होगा. आपको एक डॉक्टर पकड़ करके 4 हफ्ते दवा खत्म है, घर में रहना है. उससे पहले सिम्टम ड्रग का इफेक्ट नहीं आता. ये प्रूवन है अक्रॉस द वर्ल्ड. 6 से 12 हफ्ते acute phase. So it takes 4 to 6 weeks from here. अगर आपने दवा इसमें छोड़ दी तो वापस पहुंच जाएंगे. It's called remission. So अगर दवा आप लेते रहेंगे तो रिकवरी हो जाएगी. And you have to take medicine maintenance phase 1 year. So अगर आपने एंटी डिप्रेसेंट शुरू करी है तो आपको 1 साल खाना पड़ेगा. ये ध्यान रखिएगा. नहीं तो विड्रॉल सिम्टम्स होते हैं और सारे प्रॉब्लम होती है. तो आपको 1 साल दवा. So why I am telling you? So this is a very much social problem or problem unmet need. If antidepressant takes 4 weeks, got there 4 weeks, I want to get treated by tomorrow. So this is unmet need. We want to take the drugs which is effective in few hours and it stays effective. So this is called it rapid active antidepressant. So these are the all, actually there are 2 dozen drugs available, antidepressant. उनकी सारी की समस्या एक ही है कि 6 हफ्ता लेती हैं, 5 से 6 हफ्ता एक कनेक्ट लेते हैं. और आपको बताएं 50% डिप्रेस्ड सब्जेक्ट में ये सारी दवाएं काम करती हैं. We call them treatment resistant depression. 50% of the people do not respond to the currently available drugs. So कैसे इसको treatment-resistant depression, and they are classified like that. If you take the drug and it is not effective for like 2 weeks, then you switch another drug, it's still not effective, they will call treatment-resistant depression. So, just last slide I'm reaching to my point. So we had another kappa opioid receptor antagonist. I will not go into detail. There are phase 3 clinical trial going on the kappa opioid receptor antagonist, CRC501. I think it's not approved. And esketamine is approved. It costs about $5,000 a month. And you have to go to the hospital to take the shot in the supervision. You cannot have it. So this is the only available drug, esketamine, for treatment-resistant depression, and it costs $5,000 a month, once a month. You have to take one shot for a month, but it's still $5,000. Do you think common people in India afford it? So there is an unmet need. So with this background, we discovered a kappa opioid receptor agonist. Again, long story short, it screens 1200 compound, reached to this level, tested into the, this is all modeling and things like bioinformatics studies, PK done, not so great. We tested it in unpredictable model. So this is how models. So we processed the mice for 21 days of different kind of expression. So one day we'll give them elimination, they don't like lights. All these are खाना बंद कर देंगे, केस म्यूट कर देंगे, एक दिन ऐसे सारा से बदल देते हैं, तो unpredictable stress देते हैं 21 days. That might become totally depressed after 21 days. But you will be surprised to know that 40 to 50% of them don't become depressed. So if we start from 40 rats, they out of 40 will get sometimes 20, sometimes 25 depression. So it's a lot of work for us. But there are certain segments of rats which are resilient. That's another line of investigation. I'm not going to go into detail. But that's the chronic unpredictable stress model we use to test the effect. And we tested our compound, it is effective. And our TRD model is also effective, but its PK is not very good. It is not going to do right. But for the pain, we are able to get away with the peripheral agonist, but it is depression. The compound has to go into the brain. So our pharmacokinetic properties of the compound were not so great. So still we are hunting. Highly addictive. It increases the serotonergic neurotransmission into the brain. And recently, not just MDMA, several psychedelics, hallucinogens,